Hello, good afternoon everyone. Myself, Dr. Sudhir Mukherjee, an interventional cardiologist in Calcutta. I'll be discussing today regarding systemic hypertension, its management and role of diuretics. Millions of patients are suffering from hypertension or systemic hypertension, rather we should call it, and a large number of them are not controlled properly with medications. Millions of patients are in the age group of more than 50 years of age, and they are not being controlled properly with hypertension. They are presenting to us with lots of complications of hypertension and its various manifestations, from cardiology to kidney department to every aspects of their health. So today I'll be discussing regarding the management of systemic hypertension, the role of diuretics and how relevant it is, and if you are preferring for diuretics, then what should be your ideal choice. So there has been a lot of guidelines regarding the management of systemic hypertension, or the hypertension we commonly call it, be the American College of Cardiology, European Society of Cardiology, NICE guideline from UK, even we do have our own Indian Society of Hypertension guidelines. But in spite of that, a large number of patients are not being treated properly. They are not being chosen in the particular group of antihypertensive they should receive, and that is one of the reasons their hypertension is not properly controlled. So with advancement of age, we do have certain changes in our internal milieu of our health conditions, be it vascular, be it non-vascular. And one of the most important changes that happens to our health is that our blood pressure gets increased with our advancement of age, and your systolic blood pressure along with your age advances increases, and it has been proven in several other studies that the systolic blood pressure gets increased along with your age advancement. So this is one of the most important changes that we do predict in our daily to daily activities. So why this is so important? Because this is one article that was published in American College of Cardiology long ago, that this geriatric hypertension is generally of a salt sensitive in nature with a disproportionate frequency of isolated systolic hypertension. How do you define isolated systolic hypertension? Well, your systolic blood pressure is more than 140 mm of mercury. At the same time, your diastolic blood pressure less than 90 mm of mercury. That is how we define isolated systolic hypertension. So a large number of patients in this age group, in this geriatric age group, are suffering from isolated systolic hypertension, and the maximum of them are basically salt sensitive in nature. So this often poses a problem in our daily activities. When a patient comes to our clinic with a systolic blood pressure say more than 140 and diastolic blood pressure less than 90, we often do consider whether to start treatment or not. That is one kind of a thing that we often think that okay, that may be a error of judgment, we should not start your antihypertensive treatment, we should wait. But I would like to remind you that this is one of a very important kind of group. This isolated systolic hypertension needs to be treated properly. Why so? Because this systolic blood pressure, which gets increased with your advancement of age, is very important. It helps to predict the risk of coronary heart disease, coronary artery disease, left ventricular failure, congestive heart failure, cerebrovascular accident, and even renal failure. So it has been seen that after the age of 50 years, your systolic blood pressure is the most important rather than the diastolic blood pressure, which helps to predict this kind of complication the patient might be suffering in near future. So controlling systolic blood pressure is very important. Second important thing is that in the Framingham heart study that you have perhaps seen, that if you consider systolic blood pressure as a measurement of main measurement of your defining hypertension, then almost 99% of the patient actually can be categorized in the grade 1 or grade 2 according to the current status. But if you consider the diastolic blood pressure, it has been seen that only 66% of the patients can be categorized in a particular hypertensive zone. Therefore, systolic blood pressure has always remained very important from this management point of view. Now, why this has been so, that the increase of systolic blood pressure with advancement of age? The main important things are two. Number one, with increase of your age, your artery, the vascular system gets stiffer and your arteries get more rigid. That results in reduced compliance of the vascular system, and that is why, that is the one of the reason that your systolic blood pressure increases with age. At the same time, the diastolic blood pressure gets decreased. So this isolated systolic hypertension poses a problem because there is increase in the pulse pressure zone, and if you draw a pulse pressure wave, then you will see that there is increased pulse wave amplitude, and this increased pulse wave amplitude actually very much detrimental for the whole vascular system. Therefore, it has been very important to control the systolic blood pressure. Another important thing which happens with advancement of age is that the reduction of the renin plasma activity. Say a patient of 30 years of age comes to your clinic and you detect that he has been suffering from hypertension, systemic hypertension, then the reason has been always there that maybe the increased adrenergic activity, high plasma renin activity has always been in our mind. But remember, in this elderly population, this is not a factor. So therefore, all drugs will not be working in this age group for proper control of blood pressure. This has been a picture. You can easily discern that the red line is for the plasma renin activity and the blue line is for plasma aldosterone level. And you can see that with advancement of age, the plasma renin activity, the supine plasma renin activity and aldosterone plasma level as a function of age in healthy normotensive subject, normotensive person, getting decreased. So this is one of the important changes that happens in the elderly population who are suffering from systemic hypertension. To remind you about the impact of systemic hypertension, that systemic blood pressure in 2015 was a leading global contributor to premature death. More than 10 million deaths have been reported worldwide. 212 million dollars lost in 2015. Death and dollars attributable to systolic blood pressure have increased 1.4-fold since 90s. And systolic blood pressure more than 140 mm of Ag accounted for most mortality and disability burden. Largest number of these systemic blood pressure related deaths were due to either ischemic heart disease or it's a cerebrovascular accident, be it a hemorrhagic or it's a ischemic. So controlling systolic blood pressure has always remained very important. So there are a few questions that you should keep in your mind, that do we detect it effectively, do we treat it well, and do we control it and eliminate the associated risk. So in this age group, treat this patient differently because different mechanism, different pathophysiology, and you need a different treatment for this. Of course, the importance of diuretics and calcium channel blocker is there. Say a patient comes with 60 years of age, non-diabetic, non-proteinuric subject with a systemic hypertension. So what should be your first choice? According to guideline, you can start with any of the drugs. But remember, in this age group, the pathophysiology behind this systemic hypertension is different. Therefore, it has been always our choice to prescribe a calcium channel blocker or a diuretics. Today, I'll be discussing about the diuretics. So, why so? The choice has been like this in various guidelines because again, the reduction in the plasma renin activity, reduction in the overall sympathetic nervous system activity. That is the reason perhaps the RAS inhibitors and the beta blockers become less effective with increasing age. Like I said earlier, a 30-year-old individual with a systemic hypertension, the beta blocker is very much effective. But when a patient comes at the 60 years of age, you might be thinking about before prescribing beta blockers only for hypertension, unless and until patient has certain other indication for it. Therefore, diuretics and calcium channel blockers are more effective in this age group for controlling blood pressure. So diuretics as a drug of choice in salt-sensitive hypertension has always been the mainstay of treatment. There has been several guidelines. Sometimes they have underscored the importance, sometimes they have undermined the importance, but diuretics has always been the mainstay of treatment for hypertension, especially in salt-sensitive individual, and of course one cannot deny the importance in case of resistant hypertension. So these are the few recommendations, the gold standard of antihypertensive therapy. Several JNC guidelines have kept diuretics as first line. American Heart Association guidelines has also given recommendation for diuretics as the first line patients above 55 years. No individual can be labeled, this is very important, no individual can be labeled as resistant hypertension unless a diuretic agent along with two other agents are being prescribed in optimal dose, maximal tolerable dose. So that is very important. Therefore, diuretics, particularly thiazide and thiazide-like diuretics, have been considered as gold standard of antihypertensive therapy, especially in uncomplicated primary hypertension. Now, there has been lot of trials, lot of studies which have shown that thiazide-like diuretics are basically better than thiazide diuretics. And it has been shown, it has been published from long ago that thiazide-like diuretics give you much more CV benefit, much more cardiovascular effectivity, less mortality compared to thiazide diuretics. Therefore, if you are thinking of diuretics, better to think about the thiazide-like diuretics. These are the recommendations for ESC recommendations. As a first-line agent for initiation of antihypertensive drug therapy, first-line agents include thiazide-like diuretics, calcium channel blockers, and others that you are quite aware of the facts. Recommendation for choice of initial monotherapy versus initial combination drug therapy. That is also sometimes a question and debatable. But for the latest guidelines have clearly recommended that BP more than 20 to 10 millimeter of mercury above the BP target level, that is a grade 2 hypertension, you should always choose as a twice therapy, two drug regimen therapy, and one of them is better to get diuretics. Either it may be your first choice or maybe a second choice with any other drug. So diuretics is very important in controlling blood pressure in systemic hypertension, especially in the elderly population. So all hypertensive agents are recommended and can be used in the elderly, although diuretics and calcium antagonists may be preferred in isolated systolic hypertension that I have been talking about, especially in the elderly population where you get a systolic blood pressure high more than 140 mm of Hg and diastolic blood pressure less than 90 mm of mercury. These are again another guidelines from NICE guidelines that it is clearly saying that it's a very beautiful guideline, NICE guideline if you go through it. That if diuretic treatment is to be initiated or changed after a thiazide-like diuretic such as chlorthalidone or indapamide is preferred to hydrochlorothiazide. This rule has been clearly established. There is no doubt that if you are thinking of diuretics, then thiazide-like diuretics would be your first choice rather than thiazide diuretics, because thiazide-like diuretics give you tremendous CV benefit. Therefore, you do have a choice of either chlorthalidone or indapamide. So, safest thiazide-like diuretics for Indian patients, what should be? Now, every diuretic has its own adverse side effects. There is no doubt about it. This is the Indian Hypertension Guideline 2013 that clearly said that indapamide's use has been shown to be associated with minimal metabolic side effects and is a useful agent. So, if you are prescribing any diuretic, be it thiazide-like diuretics rather, chlorthalidone or indapamide, then we are always thinking of the metabolic side effects, the other adverse effects these diuretics can be occurring due to the prolonged use of these kind of drugs. So we should always think about this as a chlorthalidone and indapamide, but always keep in mind about the side effects. This is the thing that despite robust clinical data, this was published in Indian Heart Journal, I think in editorial column. Yes, I truly agree with the fact that despite robust clinical data, the use of diuretics in real world practice has continued to decline. I don't know why this should not be the case, because from long ago, diuretics has always been the mainstay of treatment, and it is a very useful drug. Be in the elderly group, even in the non-elderly group, patients suffering from any CV disease, non-CV disease, even in the stroke group, diuretics has established its role always. So this should not be the scenario. You should prescribe diuretics properly, because that gives you tremendous benefit. This is one of the trial. This is very important trial, the HYVET trial. I'll be talking little about this HYVET trial. This was a trial. It's the first kind of trial in the elderly populations, and that showed that controlling systolic blood pressure gives you tremendous benefit. Before that, people have a doubt that whether you should control in this age group, whether to systolic blood pressure lower or not, because sometimes patient comes with several complications of low BP. But this HYVET trial, this was based with indapamide, that show a clear-cut significant benefit of controlling systolic blood pressure to below target level. All-cause mortality benefit was almost 21% with indapamide, and the stroke risk was down to 39%. That is significant benefit of controlling systolic blood pressure in the elderly group. And after that, the scenario actually changed, and this trial actually changed the whole guideline. Now we are prescribing at a level that yes, you should lower your BP even if you are an 80 also, then you should lower your BP to the target level, and that can give a tremendous benefit from all-cause mortality, CV mortality, and stroke benefit. So HYVET results led to change in guideline recommendation for elderly hypertensive patients. So therefore, this was a meta-analysis from SRE and published in 2011 from several multi-center trials that if a clinical indication calls for a thiazide-like diuretics, thiazide-type diuretics, indapamide or chlorthalidone remain the drug of choice. And now I'll be talking little about this chlorthalidone. Chlorthalidone also gives us significant cardiovascular benefit, and that has been established in several trials like SAFE trial, SHEP. But remember one thing, whenever you are using chlorthalidone, the dose should be properly given to patients for this significant CV benefit. If you follow the SAFE trial, then you will find it that the chlorthalidone dose used was 25 mg. And if we think about the side effect profile, then we will find that 3.8% are hypokalemia. That's a pretty large number of patients complain of hypokalemia. Well, every diuretics has a hypokalemic effect, you cannot deny it. But the main problem was 6.5% had new onset diabetes. In India, we are already having a large number of diabetic populations. In this scenario, if you are prescribing any drugs and if you are getting this 6.5%, that's not less, a large number of patients developing diabetes, then it's a pretty worrisome thing. Second trial was a HDFP trial, and that also showed us a significant mortality benefits in chlorthalidone. But again, if you follow the dose, you will find that 25 mg was a minimal dose. And due to high dose, almost there was 17% discontinuation of the drug due to side effects. And most importantly, almost 8.3% of the patients reported a sexual side effects in form of erectile dysfunction, lack of sleep, other things also. In the all-heart registry, that is the largest registry and largest trial, the chlorthalidone doses was used from 12.5 to 25 mg, and this trial also showed that 1 in 8 patients needed potassium supplements, and almost 12%, 11.6% exactly developed new onset diabetes, that is no less. Therefore, if you are prescribing chlorthalidone for significant CV benefits, as per the trials are established, 12.5 to 25 mg should be the moderate dose. And this has been said clearly by the American Heart Association also, that for optimum endpoint protection, the thiazide chlorthalidone should be administered at a dose of 12.5 to 25 mg per day. Lower doses are either unproven or less effective in clinical outcome trials. So for CV benefits, whenever you are prescribing chlorthalidone, the dose must be in this range. But whenever you are prescribing 12.5 to 25 mg, I don't know about 25 mg, if anybody is prescribing in Indian scenario, I am getting a lot of complications, probably not only for of hypokalemia, but other things also. And new onset diabetes is definitely a worrisome thing for us, especially in our scenario. So this is a study literature published in Indian Heart Journal showing that 25% of men treated with 25 mg of chlorthalidone per day develop a decline in sexual function and sleep disturbances. These are also various complications of high dose of chlorthalidone. Chlorthalidone has been shown significantly affect this sexual health activity also. And considering all heart registry, new onset diabetes is definitely one of the things you should keep in mind whenever you are prescribing chlorthalidone. Requirement of potassium supplements should always be kept in mind because hypokalemia is pretty common with diuretics. Therefore, all thiazide-like diuretics are not metabolically neutral. So for a similar reduction in blood pressure, chlorthalidone causes a significant and persistent 23% increase in sympathetic nerve activity. That is also something that was not there previously. Before you prescribe chlorthalidone in elderly population, that was supposed to be less. But whenever you are prescribing chlorthalidone, it has been seen that the similar reduction, there is significant increase in SN activity. Apart from that, chlorthalidone also increased insulin resistance, which may be responsible for this new onset diabetes. Considering indapamide has a better metabolic profile. If you think of these two curves, that total cholesterol, fasting glycemia and triglyceride. They have shown in this picture that very clearly and very beautifully that indapamide is basically metabolic neutral from glucose point of view and from lipid point of view also. Therefore, there have been a lot of meta-analysis considering and comparing indapamide vis-a-vis chlorthalidone and separately also for CV outcome as a primary endpoint. And this article actually published in Indian Journal of Hypertension. Almost more than 2 lakh patients were included. And the bottom line was that the effects of blood pressure lowering on outcome incidence in hypertension regarding indapamide versus chlorthalidone show a significant favorable trend in aspects of indapamide. The all-cause mortality benefit was significant in indapamide compared to chlorthalidone. It was 27% reduction compared to 12% reduction in CTD. And in case of CVD, as a secondary endpoint, it was calculated. In CV death, it was a 18% benefit in indapamide compared to 10% in chlorthalidone. And overall stroke benefit was very much important. Stroke benefit was 34% in indapamide group compared to 25% in chlorthalidone group, which was found to be statistically significant. Therefore, indapamide as a whole among the thiazide-like diuretics was found to be very much effective compared to chlorthalidone and other diuretics. These are the number needed to treat for indapamide vis-a-vis chlorthalidone. For stroke, it was found at 29 only, whereas in case of chlorthalidone, 40. In case of cardiovascular death, the number needed to treat NNT value was 55 for indapamide. In case of CTD, it was 96. All-cause death was also lower NNT, 37 only for indapamide group, whereas 82 in case of chlorthalidone. Therefore, still if you do have any doubts, then you can go to any other published literature regarding indapamide and chlorthalidone. You will find these metabolic effects of chlorthalidone vis-a-vis indapamide. Indapamide has a better safety profile compared to chlorthalidone. And if you ask me why indapamide has such good metabolic effect, I would rather probably say that one of the reasons for this salutary effect of indapamide could be its predominantly vascular effects. This may be minimizing the risk of diuretic related side effect as well as other metabolic complications. So not all diuretics are equal. I would like to say that not everybody is equal, so not all diuretics are equal. Thiazide-like diuretics are definitely should be your choice of drugs for hypertension, and in that scenario, indapamide definitely advances much more compared to your counterpart of chlorthalidone. So to conclude the session, I would like to say that diuretics has remained the first line therapy in management of uncomplicated primary hypertension. Lower dose diuretics decreases side effects. Lower dose hydrochlorothiazide is a weak antihypertensive effect and does not seem to reduce CV outcomes. Low dose chlorthalidone is effective and also reduces some CV outcome, but metabolic side effects, though reduced, still persist. Indapamide, which is not only effective but also consistently reduces the cardiovascular outcome, including all-cause mortality and stroke, is a very effective drug and should be your mainstay of treatment, especially in elderly populations when you are getting isolated systolic hypertension or systolic blood pressure of the chart. Therefore, indapamide should always be your mainstay of treatment in this age group. And with that, I conclude the session and thank you all for watching and thank you all for listening. Well, there is a question regarding from Mr. Kapil Keswani. That sir, is that Natrolix SR is effective in North India patients because those patients having more sweat in the Europe, the Europe or American patients? Well, I would like to say that I really don't know whether they are much more sweating people than Europe and American, but yet one thing is very clear from the study that was published in Indian Heart Journal. The large number of population was from North India also, and it has been seen that the salt-sensitive hypertension, which is common in elderly individual, is they do sweat a little bit more compared to salt-resistant one. Therefore, I think indapamide definitely works in this age group. and in these categorical patients, because elderly population and salt sensitive hypertension, they both categories were included in the HYVET study. Therefore there must not be any such issue that it might not be working, and North Indian populations were included in that study in a large number. Therefore Diuretics SR should be working in this age group also. Is there any trial which showing the green flag to Netflix? Yes, Indapamide has been trial in the HYVET trial, as I have already told today. And HYVET is one kind of a trial you can trust. It's a large number of patients, elderly populations, and basically guideline changing trial. Before that, we are of the thinking that we might not be lowering in the BP in the elderly population, that might be dangerous. But yes, HYVET has totally revolutionized the concept of treatment of hypertension in this age group, and that is the most important trial for indapamide, based on which indapamide has been prescribing, people has been prescribing, physicians are trusting indapamide. That's a very important trial. You can go to the HYVET trial, you will understand they have categorically included every bit of patients, elderly, salt sensitive. So therefore that's a very good thing, and that's give us the green flag to prescribe indapamide. I think HYVET is one of the most important and exclusive trial ever done in history of hypertension. Well, currently I do not think there has been any trial on Natrelix only, but vis-a-vis whenever we are taking any particular study group, a large number of patients also been prescribing indapamide. Based on that, we can conclude that indapamide has been very effective in the Indian population, of course. Thank you. Any more question? If people have any more question, then you can ask me freely regarding indapamide in different categories, not only in elderly population but also in so-called less elderly populations. Any metabolic side effects regarding vis-a-vis chlorthalidone, thiazide, any options, you can ask me freely. And if there is no more question, then I think everybody is of the same opinion that the indapamide is a very good drug, and definitely it has been so. Diuretics will be your main choice. Do not hesitate to prescribe diuretics, even if a patient, I think even we do often prescribe ACE inhibitors and angiotensin receptor blockers, because that gives you tremendous benefit in diabetic patients, even in proteinuric patients. But when a patient comes to your clinic for the first time, and if you record a high BP, what should be your first choice? You do not know the status of the patient, whether he is diabetic, whether he is having dyslipidemia, whether he is having any other heart disease, whether his renal function is deranged or not. In that scenario, you always think of the better prolific antihypertensive, and in this scenario only two things comes in our mind. Frankly speaking, I think of calcium channel blocker and diuretics. Now the problem with calcium channel blocker is that some patients have the ankle edema, and when you prescribe calcium channel blocker, they come after 1 week or 2 weeks, or either they do not come, they lose your patients. So better to start with a low dose diuretic. That has always been the guideline recommended therapy, and always been beneficial for the patient also. Remember one thing, that in elderly population, large number of patients also having ischemic heart disease. They may have lower LV dysfunction, and in that scenario also they may also have some pulmonary congestion. Therefore these diuretics also relieves all kind of symptoms. Apart from being metabolically neutral, it is also gives a tremendous benefit, and patient comes with a relief of decongestion, relief of symptoms, even the edema gone. They are very happy with this. And now you have the whole lot of sets of other parameters like renal function, like heart parameters, like metabolic. Then you can guide your treatment, whether you will add the second drugs or you increase the dose. So as a first choice, I think as a low dose diuretics is a very good. And if you think of diuretics, please think of thiazide-like diuretics, because it has already been published and already established that thiazide-like diuretics give you significant CV benefits. So you must not deny the patients of the benefit they should be getting. And when you think of thiazide-like diuretics, it is better to have a look on indapamide because the metabolic effect is tremendous. You do not want your patients to be having diabetes after 2 or 3 years. And second issue is that all your this hypokalemic effect is much comparatively less in indapamide. And I think indapamide is a very good drug and should be your first choice of drugs, especially in elderly populations when you do not know the status of the patients. Well, Kapil, I think I have prescribed a lot of indapamide in isolated systolic hypertension. In fact, a lot of patients I have seen isolated systolic hypertension. I have seen patients who are getting referred from other primary physicians because they are afraid that whether you should treat a 150 millimeter of mercury systolic blood pressure with 80 millimeter of mercury diastolic blood pressure or not. Yes, there are clear-cut guidelines. We do have strict guidelines regarding that. You should treat isolated systolic hypertension, as I have shown you earlier that treating or lowering systolic blood pressure, lowering systolic blood pressure of 10 millimeter mercury gives you almost 31% risk down for the occurrence of stroke, CVA. So this 31% benefit by lowering 10 millimeter of mercury is very important in this age group. And isolated systolic hypertension, I have been treating with indapamide. They are very good. The patients are devoid of less side effects and they are having good control of BP. Of course, you may need a second line drug. There is no deny of the fact. That depends on your choice and that depends on other health condition the patient being suffering, whether having suffering from myocardial infarction, whether suffering from CVA, whether suffering from dyslipidemia. But yes, there is no denying that you should prescribe a diuretics because unless and until you do prescribe diuretics in this age group, I have not seen a single patient who are getting benefit or getting symptomatically better without it. I think no one is asking, so everybody is satisfied.
Yeah.
Thank you very much.
Thank you, sir.